Everybody. It's Jessica Shurer here. You've heard from me before in this family conference, but I'm the Director of Clinical Affairs and Advocacy here at CurePSP. Boy, it's really nice not to have laryngitis anymore when I hear those videos from me in Philadelphia last month. But I am here for a live question and answer session with Dr. Andres Deik from University of Pennsylvania, one of our wonderful centers of care and our partner in this family conference. So I wanted to take this opportunity to ask him some questions. We do have some questions that some of you had asked when you registered for this virtual family conference today, but I want you to also take advantage of the chat in the platform that you're viewing this on. So we do remember that this is not meant to be medical advice. And if you could try to withhold from sharing very personal health information or questions, make sure to share those personal ones and concerns with your own team. But if you have questions, please put them in the chat. Before we get started, Dr. Deik, hi. Anything you want to, add before we open it up for questions?
Sure. So hi, Jessica, and hello, audience. Thank you so much for inviting me to talk. It's really a pleasure to be here with you all. And I'm happy to address any questions you might have regarding multidisciplinary care in atypical Parkinsonian syndromes, but abroad too. So if you have other questions you'd like to ask me about atypical Parkinsonian syndromes in general, I'm happy to address those. Just feel free to put them in the chat. And yes, I will echo what Jessica said. Just to protect your privacy, please try to avoid putting any personal identifying information in the chat.
Yep, exactly. All right, well, wonderful. So first and foremost, thank you everyone for being with us for this 2-day virtual conference. And thank you to those who were able to join us in person in Philadelphia last month, where we were able to record these presentations. And then, as you see, we were able to bring some of our speakers back to answer your questions. So Dr. Deik's presentation during the family conference was specifically around multidisciplinary care. And he had shared with everyone about their very unique and extremely comprehensive model for their multidisciplinary care for people with PSP, CBD, and MSA. So I wanted to start with a question for you, Dr. Deik. I recognize, and you and I were talking about this a little bit before, that so many people who are probably tuning in today, watching this, or might watch the recorded versions later, they are not from the Philadelphia area or perhaps surrounding area to be able to come to your clinic. And I know that UPenn is one of our 30 centers of care, and about half of our centers of care offer kind of a similar, they're all a little bit different, multidisciplinary clinic for atypical Parkinsonism. But even still, most people don't live near a center. They're seeing a movement or memory disorder specialist or maybe a general neurologist in their local community and may not have something like the COPE clinic available to them. So I'd love if you could speak a little bit more broadly around the multidisciplinary model and sort of what the core of that model is that someone can apply to them regardless of where they seek care for their diagnosis.
Yeah, I think that's a great point. The U.S. is a huge country, and if you think about the amount of centers throughout the country that offer these services and the general population, you can definitely see that it's not the easiest for everybody to be able to locate and access the services that these centers offer. So I think there's a few options. In general, of course, CurePSP is a fantastic resource that all of you are able to access, and you can check out there which centers do offer their own version of the clinic. And you can start by seeing whether any of these centers are in any kind of reasonable proximity to you. That may or may not work, of course. You might live much farther away from any of these centers. And then there's other options that you could consider. One option is telemedicine. So some of these centers, like ours, for example, are able to offer our services now through video. Of course, there's legislations regarding offering care outside state lines, but that aside, if you live within a state that offers a clinic, you could always inquire whether that state offers their services through video. And that might be a way of not having to travel physically to the center and still really getting this input from all of the members of the team. So that's another option, I would say. But even when that is challenging, and again, there's 15 centers in the country that do it, and there's 50 states in the US, I think the key lies in what you said, Jessica, about understanding what the core elements of the clinic are. And I think if you can identify these resources, it might take a little bit of initiative, but I think it is possible to work with your local neurologist to try to create your own mini version of the clinic, if you may, where you have identified that, yes, I need to have my neurologist kind of be in the center of it, but you also need physical, occupational, speech therapy, palliative care, nursing, social work, and knowing that all of these services are, I would say, the services that are common among the different centers. You can get a sense that perhaps if you are able to access these services locally, and I would certainly encourage your neurologist to step in and provide you those resources of perhaps word of mouth, or perhaps providers that your local neurologist has worked with, who he or she knows that have some sort of Parkinsonism background or expertise, then you could, in a way, create your own version of this clinic that is geographically reasonable for you. And even if these providers don't necessarily have a training in atypical Parkinsonian syndromes, I think there's something to be said about accessing these resources, even when they have more of a general approach. Issues like swallowing, falls, cognitive issues, mood issues, I think are certainly universal among these conditions. And I'm sure that providers who might not necessarily have the background would still be able to provide input that is meaningful, and perhaps much more so given their training than what you can get only from your neurologist. So I think the key is understanding that as neurologists, we have these sort of 360 views of these conditions, and we know how to manage very well certain aspects of the conditions. But for example, I wouldn't pretend or claim to have the knowledge that a speech therapist has, for example, to address communication and swallowing issues in these patients. So I think it's important to recognize the limitations of our training and understand that accessing people who might have that expertise would certainly work in your benefit. So my recommendation would be that if you're unable to locate a clinic that you can attend to personally or virtually, just knowing that it is possible to work with your neurologist to access these services. And many of the offices of neurologists do have some of these services as part of their centers. But then when they don't, it's just knowing that, okay, well, my neurologist doesn't really work with a speech therapist, but I know that it's important for me to see one. So I'm going to work with my neurologist perhaps to see if I can see somebody who is not necessarily affiliated with that practice. So I think just understanding the value of these model of care and trying to improvise, I guess, make it a little bit of your own.
Yep. Yeah, exactly. I mean, all excellent points. And at the end of the day, I mean, it's ideal to have a team who's very specialized in these diseases, but that is rare, unfortunately. And it is something, spreading awareness and educating providers about these diseases is a priority here, but for a long time, that's going to be rare. But also, ultimately, it's about the team that you're needing. And no matter if it's someone who's very specialized or not, or like even if you live near one of these clinics.
Sure.
Well, so many people don't live near the clinics, even if you live in a state where one of these is available and then you drive home 2 hours, you still have to figure that out. But ultimately, it's about what you're needing. And a lot of times, I would just add that I implore patients and families to advocate for themselves with their team. Like if your neurologist is not bringing up one of these rehab specialists or a palliative specialist or somebody else, if you are noticing symptoms in these different areas, or you have questions or concerns, you don't have to wait for your provider to say, hey, I think we should refer you to one of these. You could also say, this has been a challenge for me or a new development recently. Do you think that I should get evaluated by somebody? And it's tough. It's tough when you don't have one of these specialty clinics where it kind of the burden of like that coordination falls on the family. No. But you're that patient-centered care, you're at the center of that team, no matter what that team looks like. So then you could also advocate to that team, like, hey, I need you to share your notes with these other people and make sure that you're talking to one another.
Yeah, I would agree. I mean, communication is key. I think, in the centers, it's very cohesive and it's very organic, right? Like it's just a clinic that is designed towards cross communication. But when the care is more fragmented, then yes, I think it does take that extra step of, well, did the occupational therapist report back to the neurologist? Did the neurologist report back to the physical therapist? And we all, of course, live busy lives. And, it's not always the easiest, but it's certainly very important. I think if you want to have coordinated care, everybody has to be on the same page. And I agree with you. I think you need to be your own advocate, not you, the patient, but you, patient and family. And I think if you're noticing that there are areas where the communication can be improved, then I think it's perfectly reasonable and acceptable to raise that as an issue. And I'm sure your neurologist would be happy to correct it. So that feedback, I think, is crucial to make this work.
Question for you that we had received in the registration. And then I'll speak to it a little bit more broadly too. So the question was, how do I best prepare for a day at a clinic with a similar structure to the Coke clinic? And I would like to also make that broader to say, not like if you're going to any appointment, maybe not one necessarily that has a similar structure to the Coke clinic, but you're going to go see someone on your care team. How do you prepare for that? And how do you make sure that that is focused on your primary needs and concerns and your goals for care?
Yeah, it's an excellent question. I think, the time during the clinic and any clinic really is limited. So you really want to make sure that you maximize your time. You don't want to go to a doctor or a therapist or some sort of provider and not make the best out of that time. And I think there's a few key steps that are really, really important. The first step I would say is if you're coming to a center that you've never been to before and they don't know you, it is important to bring with you records from previous doctors. Now, ideally, those records can be administered to the new doctor or provider you're seeing in advance so that by the time the doctor is with you, they can really focus on you. And then they've already reviewed the records and have a very good sense of what the diagnostic impression is and what treatments have been tried. But if it's impossible for whatever reason to provide those records in advance, then definitely bring them with you. It really doesn't take much to go through them and really prioritize what are the most important things. I think things that are really, really important, any diagnostic tests that have been done, you definitely want to make sure you bring those. You also want to make sure you bring the note from the last doctor who saw you, just so that gives your doctor or your provider a sense of what the current issues are and what are the current treatment strategies. But you also want to provide the note, if possible, from the first time you saw a doctor for your current problem. And that just gives the providers such a great overview of how quickly or not your disease has moved along, and how things have changed. Like, what did you look like when things first started? And how do you look now? And, sometimes it's really hard to recall when somebody has had these conditions for many years and you've seen different doctors. It can be really hard at some point to go back and say, like, well, did I really fall before I had a tremor, or was the speech problem the first thing? But if it's documented, it's documented. It's just very easy to see. And many times the clues to the diagnosis lie in understanding what were the first symptoms that showed up. So it's really, really important for us as physicians to get a good sense of the timeline and events have transpired in that time. So that's one thing. The other thing I think that is really, really important is the list of medications. So for us to know exactly what medications you're currently taking or have taken in the past. And in regards to the current medication, sometimes patients have very complex medication regimens that include medications that have specific times at which they're administered and specific doses at each time. And we want to know that level of granularity. And when patients have very long lists, sometimes it's hard to just recite that off the top of your head. I know I certainly couldn't do it. So having a good comprehensive list that's up to date as of the last day before your visit, I think it's crucial so that we can understand where you are in your journey and what medication changes we could and could not try. So I think that's also really important. And then also, I really enjoy when my patients bring a list of questions and specific needs. So you've already recognized what are the things right now that you would like help with. And we will definitely try our best to offer strategies to address those. But I think being able to identify what are the things that we should really invest our time in, as opposed to trying to go through a long list of symptoms and then understanding that some of them may be more relevant than not. It's just so helpful to know off the bat, okay, we need to focus on gait, we need to focus on swallowing, we need to focus on speech. And then you can really use that time very, very efficiently. So those would be my recommendations to make the best out of your time at one of these clinics.
That last, I mean, all of those make complete sense. And the last one, I can't emphasize that enough. In the medical world, sometimes we talk about this hand on the doorknob phenomenon that we see. And I know that you know what I'm talking about. Of like, you go through your whole appointment and you ask, are there any other questions or concerns that you've had? And they're like, no, I'm good. And then literally they're walking out and their hands on the doorknob and they're like, oh, by the way, I've been suffering from severe depression, or something really major that takes a lot of time. You want to dedicate time to talking about and addressing, but it becomes like this afterthought. And so having those priorities and the goals and those main questions listed out, and that way you don't forget something. And in that 15 to 30 to 60, every clinic's different, minute appointment is so crucial.
Yeah, I can't agree more.
They might not see you for months.
Correct. And the hand. You wish you could just figure out a way to, how do I prevent this? And I would say yes. I mean, most of the time, it's a very major issue that is brought up in the last 30 seconds of the visit. And you really wish you had heard it when you first came in, because you would have dedicated 70% of your visit to addressing that. So I think it's really, really key. And sometimes patients themselves are not so sure, okay, what are my needs? And then maybe, sometimes it's a different perspective, right? When you're the one living it, for you, your needs may be A, B, or C, but then your family members recognize that D, E, and F are as important, if not more. So I think it's also coming up with a plan and working with your family members to really prioritize what you think is important, what they think is most important, and coming up with a consensus of what really needs to be addressed and how much time you want how much time you want your provider to spend on each of those issues.
Yeah, for sure. And just another great example of those open lines of communication, not just between yourself as the person with the diagnosis and the various members of your care team, but that also includes your family and who's ever in your personal support system. You want to be on the same page with them as much as possible too. So coming prepared with them and having those conversations beforehand is really cornerstone to that.
Yeah, I can't agree more.
Kind of along these similar lines and sort of taking a question we had received in the when someone registered, there's a lot that can change in a short period of time with these diagnoses. There's a lot that somebody might want to address. You could have changes to urinary function and sleep and speech, all at the same time. And there's so many wonderful members of these care teams, like your COPE clinic, but even if they're not all in the same center. What recommendations do you have for how to prioritize what kind of care you need when, because there's only so much time in the day. You can't get like 4 referrals and your entire life would revolve around these appointments. So, what advice do you give around that?
Yeah, so the way I prioritize it is, number 1 is what is the most dangerous at this time? Mm-hmm. And number 2 is what is the most uncomfortable at this time? So I think danger should always be number 1. And I would say among the things that are most dangerous are falls and trouble swallowing. So those 2 always rise up to the very, very top of my list, because I really want to do everything in my power that I can to prevent falls and to recognize changes in the ability to swallow early on, especially when patients have specific desires or plans of what they would want or not want to do if that situation were ever to arise. So that's a conversation that I usually try to have early, rather than have when the patient has already lost 20 pounds. And then, if a patient for whatever reason wanted a feeding tube, sometimes they lose so much weight that they're no longer candidates for feeding tubes. Many people don't want a feeding tube, and it's a personal decision. But I really want to know up front, if you were ever in a situation that you were to need it, I really want to know whether that's something that you would want, because patients just are not the best surgical candidates as these conditions move along. So those 2, I would say, are in the top of my list. Now, in terms of what bothers me the most, I would say that the things that bothers patients the most, 1, pain. Pain may or may not be related to the disease. In fact, many times these diseases do not hurt. But sometimes patients have complications that do come up with changes or bring up pain. And, many patients have changes in the way that their spine is aligned. And sometimes patients get very crooked, and that can be very, very painful. And pain just makes everything worse. So we're very aggressive in treating pain. And sometimes when the options fall out of our hands, we do refer patients to pain specialists to try to address that in a way that they can use strategies that we like to use strategies that don't interfere with your ability to think. So some of these medications, unfortunately, can cause a little bit of confusion and sleepiness, which can also be part of the disease. So we really want to find strategies to minimize that as much as possible. Sometimes there's no option and we just have to do it. But if there's ways around it, then we really want to make sure that that's addressed. So that's a big one. As you mentioned, depression and anxiety are also very big ones. Anxiety makes every movement disorder worse, not just atypical Parkinsonian syndromes, but tremors, dystonia, Parkinson's disease, chorea. All of them are worse when patients are anxious, and anxiety can sometimes spiral out of control, making it just very difficult for your quality of life. So we, at our center, we have 2 psychiatrists to whom we refer many of our patients, but I realize that not every center might have that. So that might be one of those services that you might want to talk to your neurologist about, whether they have a psychiatrist who they collaborate with. That perhaps could be, they could do like an off-center evaluation, because, there are medications to treat these symptoms very well, but they don't work immediately. They take some time to really kick in. So you really want to start the medications when the symptoms are mild, because you have time to wait for them to kick in, as opposed to waiting until the anxiety spirals out of control. And then you have a good 2 months there where you're taking these meds and they're not really doing what they should. So we try to identify also that soon enough that we can start the medications when the symptoms are not too problematic. And then down the list, other things that we try to address, and these are more quality of life issues, but not so much dangerous issues, are things like dexterity, your ability to use your hands and to be independent. So I would say that one would be next on my list. And sometimes medications don't help very much with these issues, and that's where I would really defer the expertise to my physical occupational colleagues, who are just fantastic at what they do, and they're very attuned to understand ways to improve your quality of life and to allow you to do the things that you want to do. I think you've heard it probably from our fantastic physical therapist, Heather, that one of the first questions that she asks patients is, well, what do you do for fun? Or what do you want to do? And I think it's really important to set these goals of understanding what kind of activities patients really cherish and value as important to their life. And sometimes the goals are unrealistic. And when that's the case, we mention that to our patients. But many times we are able to find modified versions of what they want. So if your goal is not 100% realistic, is there a second best that we can give you? Can we find an offshoot of what you want to do that is close enough to what you want to do that is actually better than where you are now? A very common example is I want to be able to pick up my grandchildren. And many patients can't, because if they do, they'll fall and they'll hurt themselves, but they'll also hurt their grandchildren, which of course they don't want to do. So sometimes the second best is like, well, how can I sit with my grandchild on our bed, for example? And yes, you're not picking them up, but you're sitting with them and they're sitting on your lap, and it's a safer way of doing what you originally intended to do. So identifying those things that are really crucial for your life is something that we certainly want to invest time in.
And for something like the last one, if it's unrealistic or just not physically possible for whatever reason at this point, it sounds like thinking through what's at the core of that, like and for that example of like the grandchildren, it's not so much the physical act of picking them up as much right. Like I want to have a role in their care and in their lives and this connection with them. So if I can't pick them up, then, how can I work with my team to make that connection in other ways? But definitely from what you shared, I heard, in terms of like prioritizing what treatments to tap into, safety first, because that's that's more urgent. And then from that, it's quality of life, which is so complicated, but, mood can impact that, uncomfortable symptoms can impact that, and also how you engage in your surroundings and in your relationships and your roles and your hobbies influence that. So it's a matter of also thinking through, like, what does quality of life mean for me? And making sure you bring that up to your team.
Yeah, and it can be very different for different people. I have patients who, for them, quality of life is to continue to paint. They painted all their life and they really enjoy it, and they really want to find out some way that they can use their hands to paint. And then for other people is how can I keep caring for my loved ones or providing for my loved ones? And then what kind of modifications can I do so that I can continue to have some form of employment, for example. So I think the context is the most important thing, just understanding where everybody's coming from, what's really important for them, and what things you can do to try to make these things possible, if not exactly how they want it, a version of what they want.
Right. Yep, for sure. So we got a question in the chat that is specific to the Cope Clinic. So maybe you can speak to this, but then we can speak to it a little bit more generally as well. So it's relatable to people who aren't in your area or can't access the Cope Clinic. They said if a patient wants to confirm their atypical Parkinsonism diagnosis with a clinical exam, would the Cope Clinic be the correct first step, or would they need to first have a visit with an individual University of Pennsylvania neurologist?
Yeah, usually the way we do it is we want if possible, a movement specialist to take first pass and to really ascertain whether what we're dealing with is an atypical Parkinsonian syndrome. Yep. So sometimes, particularly early on in the course of the disease, it can be very difficult to differentiate patients with atypical Parkinsonian syndromes from other completely unrelated diseases, for example, ALS. So a very common consult for me is, it's actually from my neuromuscular specialists who they receive patients who have been diagnosed with ALS, and then they examine them and they realize that they actually have a Parkinsonian syndrome. And the opposite goes too. Like, they send patients to me with a diagnosis of ALS, and then I realize, with a diagnosis of PSP, let's say, and then I realize that it's ALS. So I think it's really important before going to COPE or any of these multi-specialty syndromes clinics that at least the gestalt or the main category of the syndrome is accurate, particularly since these conditions are treated very differently, and the needs are also very different. So I think, again, knowing that having access to these clinics is hard, and transportation and the length of the clinic, if you really want to make the best of your time, just go to the right place. And I bring up the example of ALS because at our center too, and many centers in the country, there are ALS specialized clinics which very much look like ours. They're multidisciplinary. They have different types of providers involved, but they look at different needs. So for example, patients with ALS, sadly, have a lot of trouble with their respiratory function, and their lung function starts to decline over time. So one thing that they want to recognize early is what's your current vital capacity, so your ability to expand your lungs, and is that changing over time? That is not something that we would do for patients with atypical Parkinsonian syndromes because it's just not an issue. Like, patients with atypical Parkinsonian syndromes don't necessarily change their vital capacity.
A little bit in MSA, I mean, in a different way, but
right. With MSA, it's usually more like upper airway, like larynx, and whether there's laryngospasm and the onset of stridor, but not so much vital capacity, like lung expansion per se. And it's something that we wouldn't necessarily track at the COPE clinic. So it would actually be a disservice for you if you have ALS to come to the COPE clinic, because really what you need is somebody to monitor your vital capacity. So I would say that, and then I can understand how perhaps different centers do it differently, but in our center, we definitely prefer when a movement specialist has already seen you. And it doesn't have to be a movement specialist at Penn, it could be a movement specialist elsewhere who just, is trained in these rare conditions and can say that they very much feel confident saying that you have an atypical Parkinsonian syndrome. But that first pass, I think it's really important, just to make everybody's time worth their while. Like, you really want to go to the right place. You don't want to go to the wrong place.
Right. Yeah. Yeah, for sure. And I'll just speak to that a little bit more generally too, from my experience. So I was at UNC Movement Disorder Center for 9.5 years before I came here. And I was actually the coordinator, in addition to being the clinical social worker, of first, for a long time, our interdisciplinary clinic for Parkinson's. And then I forget when, maybe 5 years ago, when we started the interdisciplinary clinic for atypical Parkinsonism. And we kind of discovered through those two models what made sense, like where they overlapped, how we ran it, and where they needed to be different based on the needs of those different patient populations. And one of the things that we ended up deciding early on for the atypical Parkinsonism, they needed to have already been established patients in our neurology clinic with a diagnosis of PSP, CBD, or MSA. Mm-hmm. And we decided that for the reason that you're describing, that, first, it takes such a long time anyway to get the right diagnosis, unfortunately, with these diseases, that you want to make sure that, you're still in that realm where they're thinking this is the correct diagnosis for you. Because then once you have that label, for lack of a better word, that diagnosis, then you can figure out, okay, let's add to that of like, what do you need now? What do we need to get baseline measurements for? How do we tailor management and care to your specific symptoms and where you're at with your disease? And it's hard to figure all of that out when you're still in that place of like, do they have this? Do they not have it? Do they have something else? So I have found, I don't have like the statistics on all of our specialty multidisciplinary clinics across the centers of care, but I know sort of anecdotally from talking to many of them, I'd say if the majority of them, if not all of them, have that same policy of like, you need to already have one of these diagnoses or already be an established patient to be right for this clinic. But you know what, the thing is about any of these clinics, and I think this goes for the COPE clinic as well, like once you learn about them, you can ask for a referral. They have someone who screens them and they'll say, or coordinates it, and they'll say, yes, you can come through this specialty multidisciplinary clinic, or we first want to see you with just a neurologist, and then we could figure out if that's right. So that would be sort of my, my little recommendation to folks too, like ask for a referral if you're interested.
And we've done it. I mean, we've seen patients who have never been seen at Penn, and the first doc they see is us at the Cope Clinic. But they come, as you mentioned, referred by someone who we know, or at least we know, is a movement specialist, and whose level of certainty of the diagnosis is pretty high. Like, I think the purpose of the clinic as a diagnostic center is not so much as more of a treatment center for a known diagnosis. And sometimes, as you mentioned, it's so difficult. Even within the clinic, I think we have patients who, we now understand that PSP and CVD lie within a spectrum, and you can fall at the PSP end, at the CVD end, or smack in the middle. And I would say that there's some patients who we really cannot make our minds. Are we calling this PSP? Are we calling it CVD? Are we calling it both? But I don't think it's so important to know specifically where you lie within the spectrum as of knowing that you are within the spectrum. I think just knowing that you fall within the spectrum as opposed to where exactly within it is really the key here.
Yeah, I think that makes a lot of sense. Can you speak to, and sort of two sides of this, because again, I'm trying not to make it all so COPE specific, and every single multidisciplinary clinic operates a little differently. But a question we had received is, how often do you recommend people come back through the COPE clinic? So if you could speak to that, but then again, more broadly, thinking about, even if it's not multidisciplinary specialty clinic, if you're with all these different specialists you're seeing, the rehab therapist, neuro-ophthalmology, social work, palliative care, urology, all of them, like how often how do you monitor this, and how often do you tap into those different services over time? Like what's appropriate for the atypical Parkinsonism diagnoses?
Yeah, that's a great question. And it's something I struggle with because, of course, we're limited what my Medicare allows, unfortunately. Yeah. And sometimes, as much as we would like patients to have ongoing physical, occupational, and speech therapy, and especially at this time of the year, so towards the end of the year, we get that letter saying like, well, we're maxed out with the sessions that we allow. You have to wait until January 1st before coverage becomes, you become eligible for coverage again. So it's sad but true that sometimes our plans are a wrench is thrown in, not by what we would prefer, but just by coverage issues. Of course, some patients can pay out of pocket and decide to pay out of pocket to be able to continue ongoing therapies, which, if you're financially able to do that, I think that's probably the way to go. But in my opinion, and some others might differ from that, I think physical, occupational, and speech should definitely be an ongoing process, whether it's related, like it's embedded in a clinic or outside of a clinic. I think with these syndromes, it's so crucial to be able to do these evaluations periodically throughout the years and throughout the length of the disease. And there's always something they can do to help at any stage of the disease. So I think it just never stops being helpful. So I really don't understand why people would not do that. But that's just my opinion. And specific to the multidisciplinary clinic, we usually tell patients that, we warn patients at the beginning. We tell them it's going to be a long day. Bring some sort of snack, and we'll have some snacks also available for them. But it takes time to see all these patients in one day. So for many patients, I would say for advanced patients, it can be really challenging to come to the clinic, our clinic, periodically. So the options there are, you come to the clinic once, you sort of hear what everybody has to say and offer. And if it's just too difficult to come back, you can either just continue to follow with your neurologist like you've been doing and not come back, or you can come back in a modified version, perhaps virtually. And then virtually, of course, takes away the sort of the onerous piece of it of the travel and such, because you can be lying at the comfort of your home and you can select which of these services you think would you need the most. Maybe you don't want to see everybody because you're working with a speech therapist locally, but your local physical therapist is really interested in knowing what the specialized physical therapists at Penn or elsewhere have to say. So perhaps you could pick and choose which services among all the ones that we offer you want to do. So that's one model. There's another model where people do or can and do follow with us periodically, and they come back every 6 to 12 months. And what people do is they continue to follow with their local neurologist with whom we communicate. And every time people come to the clinic, there's a report that's generated, and it's sent to the patient, but it's also sent to their primary neurologist so that they can see what we've recommended and any changes in medications or devices that we've ordered or services that we've ordered. And then I think that allows patients to continue to have that kind of close to home relationship, which is so important to have, particularly in times of need. Like if there's ever an emergency, I wouldn't want us to be your only point of contact if we live 3 hours away from where you live. But having a local neurologist is just so helpful. If you fall and you land up in the hospital, you really want to make sure that you have that local neurologist. But that's not to say that you cannot check with us periodically. And never have I gotten a letter or some sort of communication from your local neurologist that they would not allow that. I think some patients mentioned to me, well, I just don't want my doctor to know that I'm here. And my question is, well, why not? I think there's nothing wrong with you seeing us. We are very upfront about the things that we offer, and we will communicate them to your doctor. And if any of the recommendations that we do and tell your doctor to, or suggest to your doctor actually help you, I really don't see the downside of doing it. I think there's this fear that maybe doctors would be upset at their patients if they see someone else, but I will tell you, we do not. I have multiple patients who see second opinions after they see me. Like I've also been on the other end of the stick, and it's totally fine. It's the way medicine works. Like, you want to be with a doctor who you trust, and if you feel like you're not getting what you want from your doctor, it's okay to look for someone else. I really don't think that should be at all a consideration.
Yeah. The priority is finding the care that's right for you. And unless a doctor has a very large ego. Yes. I very rarely found in my 10-year career here that a doctor is like, how dare they go see this other
I would say
doctor?
Neurologists, one of the things I like about neurology, we don't have big egos.
I know. I love that about neurology too.
Yeah, I think neurologists in general, for whatever reason, we're very humble people, I will say. Other specialties, and I will remain nameless about which ones, might be a little different. But I think, I think neurologists are a special bunch of people. We deal with conditions that are very tough and for which sometimes we don't have the treatments that we would want. So we all realize that the things that we can do are limited. But that's not to say that there's nothing we can do. There's always things we can do. And I think it's really, really important to find a doctor who will provide that to you. For sure.
So I have one more question for you that wasn't asked, but I just thought of it with what you shared, and then I'll move into my closing remarks. Can you speak a little bit more to, you mentioned how, there are different ways you can manage these diseases. There's still things that you can do throughout the course of the disease. And I know in my experience, a lot of times as people progress into the later stages of these diseases, we see them in clinics less and less, if at all, especially once they're referred to hospice, but sometimes even before that, because it's more difficult to get to the appointments. I know telemedicine has changed that a little bit. And the other big challenge we see a lot, these misconceptions of like, I'm at a point where they can't do anything else for me. It's not really worth my time or their time or energy. So could you talk a little bit about, what care in maybe the more advanced stages can look like, and how all of these team members, whoever is on your team, can help support you regardless of where you're at with your diagnosis?
Yeah, no, for sure. I think it's really tough when patients become bedridden, for example. It's really tough for them to be able to go to appointments. And sadly, sometimes we just stop seeing patients because they just cannot get out of the house. And I think there's also a little bit of this self-fulfilling prophecy where, well, if I can't get out of the house, what's my doctor going to do for me? And I think that's not true. I think, there's so many things we can do. I'll give you some examples. I mean, a big issue that many of my patients with advanced diseases struggle with is sialorrhea, which is very prominent drooling. And prominent drooling is very, very treatable. We have topical medications. There's these drops that people put under the tongue and really help. But there's also these injections with botulinum toxin that we administer. And they can be so helpful to improve communication, improve the ability to swallow, minimize the risk for pneumonia. So that's a very tangible example, I think, of things that we can do in these advanced stages. Something else we can do is address pain. So patients who are bedridden, sometimes they develop bed sores, or from lack of mobility, the joints really hurt because, when you don't really move your joints, they tend to get fixed in certain positions, and that can be very painful. So we can definitely help with that. And by we, I don't just mean me, but our palliative care specialists are actually trained in pain control. So they're really excellent at doing it. Physical therapists can definitely work on range of motion for patients in whom we're starting to see these contractures, just to prevent them, these joints from getting fused. Occupational therapists can be very, very helpful in coming up with cognitive strategies. So patients who are experiencing cognitive decline and issues with communication, sometimes they benefit from communication boards or other types of communication devices, voice enhancers, for example. All of those can be recommended, and you can be addressed by the occupational therapist, and they can definitely recommend what device would be best for you. And I think support too. It's really tough, not just for the patient, but for their families too, when the conditions move to these later stages. And I think we're here for you. We have a helping hand. We have trained specialists, social worker, counselors, psychiatrists who can help both the patient and their family navigate these treacherous waters and these very, very hard times. And I think it's just as important to treat the patient as it is to treat the family. So all of those things we can do. So I really just want to emphasize that there's always a role for a team. It's just that the goals are different. The goal is no longer how can I keep running? The goal is now changed to how do I not fall? But the questions are still there. The fact that what the question is has changed doesn't mean that there's just lack of questions. There's always questions.
Yep. Yeah, those are great points and really excellent examples of how you all can continue to support someone into the later stages of disease. So I don't think we talk about that enough. So I really appreciate you sharing that. Sure. We are at our time. I will let you go. Have the rest of your Friday and your weekend. Thank you, Dr. Deik, so much for partnering with us on this family conference, for the presentation that you shared in Philadelphia, that we recorded and shared again today, and for being with me today to answer these questions. It was really great to work with you and to have this conversation.
My pleasure. Thank you so much. Thank you for the invitation, and a happy holiday and a happy new year to everybody who's watching.
Thank you.